Hello guys, welcome to the Parson series, and this is part 3 of chapter number 8, and it's a very amazing and interesting chapter which is dealing with the important tests and procedures as well as clinical examination in ophthalmology. All right, so last time we are done with the photo stress test also. Today we are going to start with the field of vision. The field of vision. So what is this field of vision? Actually, it is a total area in which the objects can be seen while fixing the straight ahead. So basically, when you are seeing ahead, what are the things that you can fixate? What are the things that you can see that decides your field of vision? The extent of the normal visual field is actually limited. As I always say, anatomically, there are so many limitations. Above, you have got this frontal bone, medially you have got the nasal bone, inferiorly you have got the zygomatic bone. So obviously it is most of the times relatively free on the temporal side. So we have got the brow superiorly, we have got nose nasally, we have got cheeks inferiorly, and it is seen that the field for a white target, so we are taking just for the white light, it is 60° upwards, and 90° it is temporally, 70° downwards, and 60° inwards. So if you remember, I give you a mnemonic for this. It is S-nit. So it will be easier for you to remember this S-nit. Superiorly, then nasally, then inferiorly, and then temporally. So it is in the increasing order: 50°, 60°, 70°, and 90°. If you remember, I even do tell you in the classes that some of the books give you even this as 60°. No matter, they give you 60° for both, but again you have to always remember that superiorly is always less than the nasally, right? The extent varies with illumination, the size of the test object, the contrast, the background. There are so many things which actually decide for your visual field. Okay, now this is your three-dimensional representation of the visual field, the isopters, what you call as isopters. So these are actually called as the isopters of the vision. So this is the three-dimensional representation of your visual field. All right. Now let us see the confrontation test. This is a bedside test, and nowadays more and more questions are being asked about how you do the things. So this confrontation test really becomes important. It's a rough but very useful method. This is confrontation test which can be applied in the clinic or the patient's bedside when even patient is not able to go to the OPDs for the different examinations. You can do a rough quick bedside observation that what is the extent of the visual field in the patient. So surgeon sits facing the seated patient, and head level should be with that of the patient. When you are doing the clinical examination, these things are really important. And what is the distance? Distance is 60 centimeter. Now here what we are doing, we are confronting. So patient is and the examiner are sitting face to face. So what we are doing, we are covering the same side eyes. Side eyes are covered. So opposite eyes are actually being examined. So patient is asked to cover his left eye with the palm of his hand and told to look straight into the surgeon's left eye. He's covering the left eye and looking into the patient's left eye, surgeon's left eye, and the surgeon closes his right eye. So can you see opposite eyes are being closed here? The patient is covering the left eye and the surgeon is covering the right eye, and move his hand from the periphery towards the center. And we are always considering that the examiner or the observer is having the normal visual field. Only then you are able to compare. Okay, so he is coming actually from the periphery towards the common line of vision of the patient's right and his own left, keeping his hand in the plane halfway between the patient and himself. So we are keeping this halfway here. Okay, so when you are keeping it halfway, and slowly and gradually we have to bring it. Okay, so the movement of the hand is repeated in various parts, above, below, to the right and left, so that you can test all the fields like this. This method is extremely simple, rapidly applied. It will be seen that the surgeon tests the range of the patient's field by a comparison. So there is actually a comparison with his own field. So obviously we have to take this into consideration that the observer's field should be normal, which may be considered normal. Moreover, the surgeon is continually watching the patient's eye so that he can at once observe any deflection from the point of fixation. That is again very important. Patient has to look into the left eye of the examiner, and you have to continuously watch that if there is any deflection from this point of fixation. A hemianopic defect, suppose there is a hemianopic defect, can be easily detected if the surgeon extends his each end to the either side, especially with similarly colored objects, and ask the patient how many he is seeing. If any defect is indicated by these methods, then you have to accurately check it with the help of a perimetry. So they have not given you the interpretation. Actually what we do, we try to bring it from the periphery towards the center. Now moment the examiner starts seeing this object, because we are considering that the observer is having a normal visual field, so patient should also start seeing at the same time if he or she is also having a normal visual field. So we have to ask the patient that tell when he starts seeing. So is it at the same time when the observer also has started seeing, or it is after that? So by the help of this confrontation method, we are comparing the patient's field with the observer. All right. Now we come to the definite perimetry, where we are testing and mapping out the visual field effects. The term perimetry is actually used to describe the techniques employed to examine and quantify the visual field using the targets of various sizes and the colors. Because of the subjective nature of the patient's responses, efforts have been made to standardize the many aspects of testing so that we can keep as little variables as possible and the results can be standardized. Despite this, when interpreting a visual field defect, it is still very important to take into the account the patient's reliability. After all, you know, in the cases of perimetry, we are actually dependent upon the patient's reliability. He or she has to answer. So how much he has understood, how much truthful he is, and how much attentive he was to your instructions, how much intelligent he is to follow your instructions. There are so many things which actually plays into account while doing the perimetry. Now the threshold of differential light sensitivity measures the ability of a given eye to discern a small spot of light projected on a uniformly illuminated background. So that smallest light that can be appreciated is the threshold. Then we have got the differential light sensitivity. It decreases slowly from the macula towards the periphery, but not as abruptly as the visual acuity. So though the light sensitivity is also diminishing while we are going from the macula towards the periphery, this visual acuity is also decreasing. But yes, obviously visual acuity is decreasing more abruptly in comparison to the light sensitivity. This is described as the hill of vision. If you remember, they had given you something like this. So this hill of vision is there, so it is abruptly decreasing with the elevation representing the differential light sensitivity. Two techniques of testing are commonly employed. Now there are two kind of perimetry that we are doing. One is a kinetic perimetry, another is static perimetry. Kinetic perimetry mein what is happening? The target is moving across the field. Okay, so if the target is moving, we have got a movable target, that is your kinetic one. While when we have got the static, means object is not moving, the fixation is not moving. So we are having the stimuli of varying luminance but in the same position. So if the position is same, luminance is differing, that is static, and if it is moving, then it is kinetic. All right. Kinetic perimetry is a fast and flexible method of evaluating the visual field. However, it may miss the shallow scotomas and the isopters are difficult. This requires a skilled and patient operator. More subjective is also there, and okay, that is why the automated static perimetry has become the diagnostic method of choice. So what we are doing nowadays as a diagnosis of choice, when you are going to record the visual field, it is the automated as well as the static perimetry, right? The perimeter is commonly a half sphere situated at the patient's near point, within which a spot of light is there, can be moved to test for the retinal sensitivity. Like we have got the Goldman's perimeter, computerized one, automated perimeter. So they are something like this. Goldman, जिसमें gold dome होता है, that is your Goldman's. This one is your Goldman's perimeter, and usually it has got a light spot inside it, And this light spot, what they are saying, it is situated at the patient's near point, and the luminance will be differing, but the point will be same. Okay. Then we have got another kind. This is also there. Okay. This is the screen perimeter that we'll be talking about. Okay. Now, during the perimetry, the stimulus may be presented in 3 different ways. First of all, let's talk about the kinetic perimetry. In the kinetic perimetry, our target of given luminance. So here luminance will be fixed, but it is moved from a non-seeing area in the periphery towards the center till it is perceived. So the same thing is used in cases of the Jerem's screen and the Goldman's perimeter. If you look here, this is your Jerem's tangent screen. This is your Jerem's tangent screen. Jerem's tangent screen is there. Okay. So, and this one is Goldman's, and both of them, like Goldman's comes both for kinetic as well as the static, while the Jerem's is only kinetic. So both of them can be used for the kinetic one. Okay. This point is recorded and the process is repeated from the different directions. These points are then joined by a line that represents a given level of the retinal sensitivity, and that becomes the isopter. The size and illumination of the stimulus can be varied to allow the assessment of the areas of the visual field which are of the interest, like usually if we are interested in the central area, so that is central 30 degree is the visual field. Targets of different luminance are used to plot the various isopters. The brightest target will have the largest isopter and the dimmest will have the smallest. So this will be the crux of whole of the paragraph, that brightest target will have obviously the largest of the isopter and the dimmest will have the smallest. Now talking about the static perimetry, supra-threshold perimetry targets of a given slightly supranormal intensity. They explore the visual field in the presence of moderate to gross loss of sensitivity. Supranormal stimulus is not seen. So, if you have got a very high degree of visual field defect, you are not going to see this. However, milder deficits may be missed. Automated screening strategies. The automated parameters are using this static perimetry only, where you are having a static fixation target but of different luminance. This was your supra-threshold. Now, if I talk about the static with threshold perimetry, targets of different as well as increasing intensities are presented at the designated points in the visual field until they are just visible to determine the patient's threshold. So, this is the one that is used in the computerized and automated parameters. So, for all practical purposes, the one that we are using most commonly is the static threshold perimeter, in which you are using the stimulus of the different intensities, and you are going to record the smallest of the one which is required for the patient's perseverance, and that will become the threshold for that patient. All right. Now let's start with the kinetic. Now kinetic may, again you have got the Goldman's is for both, I told you. This kinetic perimetry chart has got the circles marked upon it. They are concentric to the macula. It is having a gold dome, and it has got many circles which are marked over it in order to help it out, corresponding to the degree. So the patient is seated with his chin upon the chin rest. If you look at the picture here, so see this. So the patient is sitting with the chin at the chin rest there, and the examiner is on the other side. Both the levels of the eye should be same, and inside we have got so many circles concentric. Okay, so they are concentric to the macula. They are attached on the arc. Patient is seated and face should be vertical with one eye occluded. See, there is no point of taking the perimetry or visual acuity or anything with both eyes open. So you have to go one by one. The other eye is fixing, will be fixing at the central white dot. This will be the fixation point. And the first field is first charted with a large white spot of light which is gradually brought in from the periphery of the arc towards the center. The patient is asked to press a buzzer when the object and not a blur is identified. So basically I told you that this is very, subjective. It depends upon the patient's response. So patient has to press a buzzer when he sees the stimulus clearly, and if it is blurred, patient will not press it. Patient has to be constantly reminded to keep his eye fixed over the central target because at times they are distracted, and at least 8 meridians must be investigated, preferably 16. An object should be carried up to the fixation point. That is very, very important. There may be areas which may be non-seeing, so those areas will be scotomas. So it's a time consuming procedure. Patient has to be very, very attentive. There should be someone lying near the patient because you have to constantly ask the patient to look at the fixation target, right? So these should be mapped out with the same accuracy, and the plotting should always be from a non-seeing area to a seeing area. So your plotting when you are doing, it should be only in this manner. Okay, don't go from seeing to non-seeing. You have to start from the non-seeing area and you have to come towards the seeing area. If the scotomas are small, limits are determined. The size of the test object and the luminance, okay, they are recorded as the isopters or the lines joining the points of equal retinal sensitivity. So after that you will be having so many points of the retinal sensitivity, you will have to join them and you get the isopter. With the small dim stimuli, relative scotomas can be found. Absolute scotomas are the one which are demonstrable with all the light intensity. So even if you are using the full light intensity and then also the patient is not able to see, that will be your absolute scotomas. So something like this you are going to have, okay. This is like the prescription paper. So the test paper that you are going to give to the patient after the procedure is something like this. So this contains the initials of the patient, the personal information, the name, age, gender, OPD number, diagnosis date, pupillary diameter, as well as the name of the investigator, so that even afterwards if a record is needed or you have to review it or you have to follow it, so you have all these things, or if the patient wants to show to any other doctor, then also we can use it at that time. And this kind of plotting is there, and the isopters are shown, okay, and whatever is the map, the ophthalmologist is going to read it, okay. Perimetry, as I told you, is purely subjective. The normal physiological response to an object in the peripheral field is to turn the eyes towards it. So in charting the field of vision, this normal response must be suppressed. Fixation being rigidly central, that is very, very important, while attention is directed to an object at the periphery. Hence the first fields, if you see, the first field should be taken should be interpreted with the caution. You have to be very, very careful, okay, that the fixation should be central, and therefore the first of the plots that you are getting over the paper, they have to be assessed very, very carefully. Now if the charts of the two eyes are superimposed, there will be a large central area which is common to both of the eyes. This is called as the field of binocular vision. So we get this separately for both the eyes, and if you are overlapping both the things, so what you are going to get, you will get a large central area, which this central area will be common to both. That means that is your area of binocular vision. Having mapped out the field for white, okay, the process can be repeated for the colored objects also. Like for example, if I talk about the field for blue and yellow, it is roughly 10 degree less in each direction than that of white, while if you compare for red and green, it is another 10 degree less. So that is why we usually measure it for the white light only. The limits of color fields may not vary with the intensity, but also with the saturation of the color, with the size of the objects. So there are three things which are actually determining the visual field. We have got number one, the intensity of the light, the saturation of the color, and also the third is your size of the object. It is frequently advisable to perform the color perimetry to investigate the central part of the visual field, especially for red and green color. because this kind of, neuropathies we are going to get in tobacco alcohol optic neuropathy, retrobulbar neuritis, they are not recognizable in these conditions, and there is central scotoma. In such a test, it is sufficient to use perimetric targets. Perimetric targets, they are actually within 5 mm in diameter, and it is found that blue and yellow are frequently recognized as such, but not the red and green. So there are so many places where this central perimetry, which is called as a campimetry, that is required, because red and green colors are affected in optic nerve lesions and blue and yellow are affected in the macular lesions. So accordingly, you have to actually check that which color deficiencies are there. So after doing it with the white color, you have to repeat this perimetry for the different colors also. So this was about the kinetic perimetry, the concept of the visual field. This is all for this session. Next time we will be starting with the static perimetry. Please do keep reading the Parsons along with me. Don't try to keep the backlog. I know there is so much to read, but obviously those who will read with me definitely will have an extra edge. Textbook reading is just awesome, and only we are fortunate enough that in our third years we have that much of time that we are reading. So those who are doing their internships or those who are preparing and do not have that much of time that they can read the Parsons on their own, it is a small effort to help you read, so that you can take your book in front of the screen and just keep on revising your stuff. All the things have already been covered in the notes, so you can easily revise the golden points which are given in the Parson, so that we get to know some of the important things which can come directly and picked up in the examination. So I hope this will definitely help you. Please do like the video. Please do comment how do you like the video. Please share the video and keep studying. Thank you and happy ophthalmology.